Arterial blood gas analysis. What is an arterial blood gas analysis? Arterial blood gas drawn from artery, that is radial, brachial, femoral. It is an invasive procedure, that is the procedure which gives pain. Why to order an ABG? Assess adequacy of ventilation and oxygenation, aids in establishing a diagnosis and severity of respiratory failure, and it assesses changes in acid-base homeostasis, helps to guide treatment plan, and helps in management of intensive care unit patients. Components of ABG: pH, partial pressure of carbon dioxide, partial pressure of oxygen, high CO3, that is bicarbonate, and oxygen saturation and B. Others include hemoglobin, hematocrit, sodium, potassium, glucose, standard bicarbonate, buffer base, standard base excess, and TCO2. Base excess. It indicates increase in the amount of buffer base. It is the number of mole of strong acid needed to adjust pH to 7.4 at PCO2 40 mm of Hg. And the base deficit, it indicates decrease in the amount of buffer base. Coming to the standard bicarbonate, it is the bicarbonate concentration in plasma in a completely oxygenated blood sample at partial pressure of carbon dioxide of 40 mm of Hg at 37 degrees Celsius. SBC, that is above 24 millimole per liter, indicates metabolic alkalosis, and SBC, that is standard bicarbonate, less than 24 mmol per liter, indicates metabolic acidosis. And buffer base, it is the total equivalent concentration of all anion buffer components of blood, normal value equal to 48 millimole per liter. Standard base excess. It gives a view of the base excess of the entire extracellular fluid. It indicates average hemoglobin of the fluid space through which bicarbonate distributes. And the standard base excess is the value when the hemoglobin is at 5 gram per deciliter. Total plasma carbon dioxide, that is the total content of the carbon dioxide, normal value equal to 27 milliequivalent per liter. Coming to the normal value, pH 7.35 to 7.45, partial pressure of carbon dioxide 35 to 45 mm of Hg, PaO2 80 to 100 mm of Hg, high CO3 22 to 26, oxygen saturation 95 to 100%, base excess B plus or minus 2 milli equivalent per liter. How to draw an ABG? So how we have to take the sample for ABG? We need equipments, site selection, contraindication. We should know the contraindication, puncture procedure, post-puncture procedure, because here we are going to puncture the artery, the blood supply will be very forced, and sample handling. Equipments: 1 cc to 5 cc vented pre-heparinized plastic syringe, 120 to 25 gauge 1 to 1.5 inch needle, longer needles for brachial and femoral artery puncture, 1 biohazard labeled plastic bag, 2 1 into 1 inch sterile gauze, and alcohol prepared pad, specimen patient label, iodine pad, and adhesive bandage, lab form, and few ice cubes. Site selection: radial artery, we have to select at 45 degree insertion angle, brachial artery 60 degree to 90 degree insertion angle, femoral artery 90 degree insertion angle, dorsalis pedis artery or posterior tibial artery. Angle of entry, here we can see the 45 degree insertion angle for radial artery and 60 to 90 degree insertion angle for brachial artery. Coming to the contraindication, no absolute contraindication. So mainly we have to make sure that the patient has a dialysis shunt. If the particular arm the patient has dialysis shunt, means we have to select the opposite side. And mastectomy also you have to use the opposite side, and the patient on anticoagulant or aspirin therapy may have to hold pressure on puncture site longer than normal, because the patient receiving anticoagulant aspirin, there may be cause bleeding. Site specific contraindication: radial, Burgers disease, Raynaud's disease, absent ulnar collateral circulation, and arteriovenous dialysis shunt, and femoral, any local infection. And coming to the puncture procedure, check for orders, explain the patient about compression of puncture site, make positive patient ID, put on gloves, assemble needle to syringe, and keep needle sterile, and eject excess heparin and air bubbles, pull back syringe plunger to at least 1 cc. 4 things that hurt: needle through skin, that is sharp; needle through arterial wall, that is blunt; miss and catch nerve, that is shooting; miss and hit periosteum, that is sharp. And site selection, radial artery is always the first choice because it provides collateral circulation. So first palpate the right and left radial arterial pulse and visualize the course of the artery. Pick strongest pulse. If radial pulse weak on right, move to left. If pulse on left weak, then try brachial. Brachial used as alternative site. Femoral is the last choice in normal situations, highest complication rate. So if you are going through femoral, it may cause a higher complication rather than the radial and brachial. So here you can see the arterial puncture site, the brachial artery, radial, ulnar, and the femoral. So puncture procedure, that is the Allen's test. So when using radials, perform Allen test for collateral circulation. In a conscious and cooperative patient, compress ulnar and radial arteries at risk to obliterate pulse, and have patient clench and release pulse until hand plunges. With radial still compressed, release pressure on ulnar artery. Watch for pinkness to return, should ping up within 10 to 15 seconds. So in a conscious patient, compress ulnar and radials, elevate hand above head, squeeze hard, release ulnar and lower hand below heart, palpate left and right radial arteries, nothing maximum pulse. The one with the stronger pulse will be your site of entry. So here you see that the doctor, how they are performing the Allen's test. So the artery which is involved, that is the nerve which is involved, median nerve, and brachial artery, radial artery, ulnar nerve, ulnar artery, and superficial palmar arch. So here you can get the idea, so how they are seeing the adequate collateral circulation from the ulnar artery to perfuse the hand. Puncture procedure, drape the bed and stabilize the wrist in the position that gives maximum pulse. So the hand should be hyperextended using a rolled up towel if necessary. Prepare the site, clean the chosen area with alcohol and or iodine. Secure needle to syringe and remove cap from needle. And pierce the skin at puncture site. Keep needle angle constant. Bevel of needle up or into the arterial flow. So here you can see the right radial artery, and after a pulse is found, a blood sample is taken from the artery. So slowly advance in one plane. When the artery is punctured, blood will enter the syringe flash. Slowly allow blood to fill syringe. If no blood appears, remove, change needle and start again. Upon removal of the needle, hold pressure on the puncture site for at least 5 minutes. Pressure may need to be held longer, more than 5 minutes if the patient is on anticoagulant therapy. So here, because since we have punctured the artery, there may be a chance of bleeding. So we have to give compression for 5 minutes, and in case the patient had taken any anticoagulant medicine and all, the patient may need the compression for above 5 minutes. check for bleeding, movement of fingers and tingling sensation, pulse distal to puncture. And the post-puncture procedure, remove any air bubbles from sample and cap syringe, dispose of needle in sharp container, roll syringe to mix heparin with the sample, immerse in ice, on lab slip indicate FiO2 to the patient oxygen level, oxygen saturation level, and the patient temperature we have to mention, and the patient is on ventilator. If the patient is in the support of ventilator, we have to write the ventilator parameters, that is the level of oxygen, tidal volume, that inspiration, expiration volume, all the things we have to write it in the ABG report form and deliver to lab. Sample handling. Sample should be analyzed as soon as possible. If 5 samples can be stored, glass syringe 1 hour, plastic syringe only 15 minutes. And we have to remember, blood is living tissue that continues to consume oxygen and produce carbon dioxide. ABG specimen collection and handling. Transport specimen to laboratory in a biohazard container. Analyze specimen on an instrument that has been recently calibrated. Temperature correction, specimen is in analyzer, increase in patient temperature, that is increase PO2 level, increase PCO2 and decrease pH. And decrease in patient temperature indicates decrease PO2, decrease PCO2 and increase pH. Blood gas analyzer. This is the machine that which we have performing the arterial blood gas. Complications of arterial punctures, that is a complication, nosocomial bacteremia, cause is inadequate cleansing prior to puncture, action ensure appropriate cleansing technique. And distal ischemia, cause no collateral circulation, clotting of artery, lack of perfusion, necrosis of tissue. And action only proceed with the puncture after patient has a positive Allen test. And numbness of hands, cause no damage. Action we have to ensure proper technique, palpate arterial wall, do not redirect when needle lies deep within tissue. And infection of healthcare provider, cause contact with the virus infections contained in blood of infected patients. And action is universal, blood and body fluid precautions should be implemented. All blood samples from all patients must be treated with full precautions. Coming to the technical causes of abnormal results. So first, room air mixed with the sample, PO2 will equilibrate to above 160, carbon dioxide will be lower due to equilibration, and delay in running sample, oxygen consumption will continue as well carbon dioxide production, and pH decreases. Iced sample will last an hour without a change in the result, and uniced ABG can be significantly changed after 10 minutes. And in case venous sample drawn, usually this is patients with the shock and should doubt when PO2 is significantly lower than expected. Drawn venous blood to check comparison or redraw sample. Heparin. Sodium heparin 1% solution should be used. Ammonia heparin will alter pH. Dry lithium heparin is okay. All unnecessary heparin should be ejected from syringe. Excess can affect results. Patient pain can cause hyperventilation or breath holding. An anesthetic may be injected prior to stick or pain, usually 2% lidocaine. Caution, some people are allergic to canes. Machine errors, improper calibration, air bubbles in electrode. Acid-base physiology. pH is the negative logarithm to the base 10 of the hydrogen ion concentration in millimole per liter. pH equal to minus log 10. An increase in pH indicates a proportionate decrease in the hydrogen, and a decrease in the pH indicates a proportionate increase in the hydrogen ion. And the H2CO3 generates 12,500 millimole hydrogen per day. Normal metabolism of proteins and nucleotides generates about 100 millimole hydrogen per day in the form of sulfuric and phosphoric acids. And coming to the calculation of pH, pH is calculated from Henderson-Kasselberg equation. pH equal to pK plus log acid divided by base, that is pH equal to 6.1 plus log bicarbonate divided by H2CO3. And Hassier and Billig modified equation H plus equal to 24 into partial pressure of carbon dioxide divided by bicarbonate. Regulation of pH. pH is maintained in narrow range in seconds by buffer system, in minutes carbon dioxide excretion by the lungs, in hours to days renal excretion of hydrogen reabsorption of bicarbonate. Regulation of arterial pH. Buffers. Buffer system minimize the change in pH resulting from production of acid. Main buffer system in humans is bicarbonate in extracellular fluid and protein and phosphate buffers in intracellular fluid. Role of the respiratory system, it is main role to eliminate of volatile acid of carbon dioxide, and respiratory centers in the brain respond to changes in pH of cerebrospinal fluid and blood to affect ventilatory rate, and ventilation directly controls the elimination of carbon dioxide. And the role of the kidney, it retains and regenerates bicarbonate, thereby regenerating the body buffer with the net effect of eliminating the non-volatile acid load. And hydrogen secretion, that is free urinary hydrogen minimal contribution, that is ammonia, phosphorus, bicarbonate reabsorption, that is proximal tubule 90% and distal tubule 10%. And carbon dioxide transport, in dissolved form carbon dioxide is 20 times more soluble in water than oxygen. 100 ml of plasma with a partial pressure of carbon dioxide of 40 mm Hg carries about 2.5 millimole carbon dioxide in solution, that is 5% of total carbon dioxide carriage. As carbamino compounds 5 to 10% of carbon dioxide carriage, and bicarbonate the remaining 85 to 90% of carbon dioxide is carried by blood in the form of bicarbonate ions. And acid-base disorders. Acidemia, pH less than 7.35. Acidosis, a process that would cause acidemia if not compensated. Alkalemia, pH greater than 7.45. Alkalosis, a process that would cause alkalemia if not compensated. 4 primary acid-base disorders, that is metabolic acidosis, metabolic alkalosis, respiratory acidosis and respiratory alkalosis. So sample versus mixed acid-base disorder. That is simple acid-base disorder, a single primary process of acidosis or alkalosis. And in case mixed acid-base disorder, there will be presence of more than one acid-base disorder simultaneously. So compensation, the normal response of the respiratory system or kidneys to change in pH induced by a primary acid-base disorder. And the compensation in the presence of acidosis or alkalosis, regulatory mechanisms occur which try to maintain arterial pH. And if any disturbances in bicarbonate result in respiratory compensation, and changes in carbon dioxide are counteracted by renal compensation. And renal compensation, kidneys adapt to alterations in pH by changing the amount of bicarbonate generated or excreted. Full renal compensation takes 2 to 5 days. And in case of respiratory compensation, alteration in ventilation allow immediate compensation for metabolic acid-base disorders. Characteristics of first degree acid-base disorders. Here the disorder, in case of metabolic acidosis, the hydrogen ion will be increase and pH will be decrease and bicarbonate will be decrease. And there will be compensatory response, that will be decreased partial pressure of carbon dioxide. And in case of metabolic alkalosis, decrease hydrogen, increase pH and increase bicarbonate, increase the partial pressure of carbon dioxide. And again respiratory acidosis, increase hydrogen, decrease pH, increase partial pressure of carbon dioxide, and compensated response there will be increased bicarbonate. And in case of respiratory alkalosis, there will be decreased hydrogen, increased pH, decreased PCO2, and compensated response decreased high CO3. Prediction of compensation. In metabolic acidosis, that partial pressure of carbon dioxide is 1.5 into bicarbonate plus 8 plus or minus 2. In metabolic alkalosis, that is partial pressure of carbon dioxide will increase 0.75 mm of Hg per millimole per liter increase in bicarbonate. And in respiratory acidosis, in acute case, the bicarbonate will increase 0.1 mole per liter per mm of Hg in partial pressure of carbon dioxide. And in chronic stage, the bicarbonate will increase 0.4 mole per liter per mm of Hg in partial pressure of carbon dioxide. And the respiratory alkalosis, in acute, the bicarbonate will increase 0.2 millimole per liter per mm Hg in partial pressure of carbon dioxide, and again chronic stage this bicarbonate will increase 0.4 millimole per liter per mm of Hg in partial pressure of carbon dioxide. Anion gap. Anion gap used to assess acid-base stasis in the metabolic acidosis. Anion gap based on principle of electro neutrality, that is total serum cautions, total serum anions, sodium minus bicarbonate plus chloride equal to anion gap, and normal anion gap 10 plus divided by minus 2 milliequivalent per liter. Albumin is the major unmeasured anion. The anion gap should be corrected if there are gross changes in serum albumin levels. And arterial gas corrected plus 4 minus albumin into 2.5. And the delta gap, difference between change in anion gap and change in bicarbonate. And based on assumption that for each 1 milliequivalent per liter increase in anion gap, bicarbonate will fall by 1 milliequivalent per liter to maintain a stable anion content. Usual range is minus 6 to plus 6 milliequivalent per liter should be 0. And anion gap equal to bicarbonate, that is pure high anion gap metacidosis. And anion gap greater than bicarbonate, that is gap greater than 6, that is bicarbonate, does not decrease as expected, that is associated metabolic alkalosis or respiratory acidosis. And in anion gas less than bicarbonate, the gap less than minus 6, bicarbonate does not increase as expected, that is associated with an anion gap metacidosis or rarely respiratory alkalosis, that is delta ratio may also be calculated. Plasma osmolar gap. Calculated plasma osmolarity equal to 2 sodium plus glucose by 18 plus blood urea nitrogen divided by 2.8. So there is a normal measured plasma osmolarity greater than calculated plasma osmolarity up to 10 milliosmolarity per liter. Measured plasma osmolarity, that is calculated plasma osmolarity greater than 10 milliosmolarity per kg, indicates presence of abnormal osmolarity active substance, that is ethanol, methanol and ethylene glycol. Coming to the metabolic acidosis. Causes of high AG metacidosis, that is ketoacidosis, diabetic, alcoholic, and the patient is starvation for long time, and lactic acidosis, type A inadequate oxygen delivery to cells, type B inability of oxygen to utilize oxygen, inability of cells to utilize oxygen, type D abnormal bowel anatomy. And toxicity is caused due to use of salicylates, methanol, ethylene glycol, paraldehyde, toluene, and in renal failure, rhabdomyolysis. Causes of normal anion gap metabolic acidosis, bicarbonate loss, that is gastrointestinal symptoms like diarrhea, pancreatic or biliary drainage, urinary diversions, and renal proximal type 2 arterial ketoacidosis during therapy, post chronic hypocapnia. And impaired renal acid excretion, distal type 1 RTA, hyperkalemia, type 4 hypoaldosteronism, and miscellaneous acid administration, that is hyperalimentation, cholestyramine chloride, and hydrochloride therapy, that is the treatment of severe metabolic alkalosis. And coming to the metabolic alkalosis. Metabolic alkalosis, exogenous bicarbonate loads, acute alkali administration, milk alkali syndrome, and effective extracellular, that is FV contraction, normotension, potassium deficiency, and secondary hyperanemic hyperaldosteronism, mainly gastrointestinal loss caused due to omitting gastric aspiration, villus adenoma. And renal loss due to the patient is using for a long term loop diuretics, post hypercapnic state, hyperkalemia, that is increased calcium level, recovery from LA or ketoacidosis, and magnesium deficiency, Barter's Jitterman syndrome, and non-reabsorption anions, and the patient using any penicillin, and extracellular fluid volume expansion, hypertension, sodium deficiency, so potassium deficiency, and mineralocorticoid excess, and high renin-angiotensin system, and accelerated hypertension, renin secretor tumor. Low renin in primary aldosteronism, adenoma, hyperplasia, carcinoma, adrenal enzyme defects like 2B hydroxylase, 17 alpha hydro deficiency, Cushing syndrome or DIS syndrome, others licordic carbaminosolone, and gain of function mutation of renal sodium channel with extracellular fluid expansion, hypertension, potassium deficiency, and hyporenemic hypoaldosteronism, that is Liddle syndrome. And coming to the respiratory acidosis. Causes of respiratory acidosis, central, mainly drugs, anesthetics, morphine or sedatives, and stroke, infection, in case airway, there is any obstruction in airway, and asthma, parenchyma, emphysema, pneumoconiosis, bronchitis, adult respiratory distress syndrome, barotrauma. And neuromuscular poliomyelitis, hyposcoliosis, myasthenia, muscular dystrophies, and miscellaneous obesity, hypoventilation, permissive hypocapnia. And coming to the respiratory alkalosis, causes of respiratory alkalosis, mainly central nervous system stimulation, structural cause, head trauma, brain tumor, cerebrovascular accident, meningitis, encephalitis, psychosis, and non-structural causes, pain, anxiety, fever, hypoxemia or tissue hypoxia, pneumonia, pulmonary edema, aspiration, and high altitude. And stimulation of chest receptors, that is hemothorax, flail chest, cardiac failure, pulmonary embolism, and mixed or unknown mechanisms caused due to drugs, salicylates, progesterone, catecholamines, xanthines like aminophylline and related compounds, and nicotine and thyroid hormone. Then patient with cirrhosis of liver, gram-negative sepsis, pregnancy, heat exposure, and mechanical ventilation. So here we can see a stepwise approach to solve acid-base disorders. Step 1, check for errors. Have the required parameters been correctly filled? Patient temperature, FiO2 special. If patient is in ventilator, we have to mark the proper oxygen level. Hemoglobin, some machine may not measure it. Barometric pressure, some machines may not measure it. Step 2, comprehensive history and physical examination. Step 3, acidosis or alkalosis. See, the pH is less than 7.35 or 7.45. Less than 7.35 or greater than 7.45. And in step 4, identify the primary disorders. Read the change in the partial pressure of carbon dioxide and bicarbonate. Step 5. Calculate the compensator response is adequately compensated. Step 6. Calculate anion gap. Step 7. Calculate the delta gap, that is unmasked, hidden, missed disorder. Step 8. Calculate the osmolar gap for high AG acidosis. And step 9. Calculate the urinary anion gap, that is non-AG metabolic acidosis. And step 10. Formulate differential diagnosis. Thank you.